Thank you so much once again to Dr. Srinivas and Cyclop team and also SCN ENT Hospital and Dr. Pradeep that I am fortunate to get another presentation in 2 days. That is cognitive behavioral therapy, which is a very new concept. I think people are they read about somewhere, but they are not using it. So this is the one therapy that we will learn about what, when, whom, and why. If we'll see, this is basically a psychotherapy and its principle is based on the social learning theory. Because when the vertigo occurs in a patient, what he is thinking like that, if I'll go to a society or a social gathering, people might think that I'm drunk. Okay, so some kind of thinking they are coming to their mind, and they are thinking that people will feel like that, people will say like that. So always they have some kind of fear. Okay, so due to that, their psychological problems occurs, that is anxiety, depression, lot of physical, emotional, and other problems occurs. So it is a psychometric principle based psychotherapy based on beliefs and thoughts. So it's developed by Aaron Beck in 1985. First, he developed this therapy. He is the top neuropsychologist in all over the world. He developed that based on depression patients. To reduce the depression, he started this therapy. Then later on, lot of things had come out with anxiety, then postural phobic patients, and other dizziness patients also we are using. We'll see it. So if we'll see the model, this is the thought process, which is an automatic process. And due to that, as I told, one stimuli is there, always that stimuli is creating impact to our thought. We are thinking like that because our society is like that. Because we are thinking, if I'll go there, I will feel like that. So some kind of internal stimuli and external stimuli, they are creating some kind of impact on our thought. And that thought is creating some emotional disturbances. Due to that, what we are feeling, like anger, anxious, anxiety, depression and stress, some kind of mood disorders. So that is also creating as an output in our behavior, that what we do. What we are doing, we're developing some withdrawal tendency behavior from this environment. We are not going anywhere to mix anybody. Some types of social handicapness coming to our behavior. So it is emphasizing the thinking, what we feel and what we do. Some irrational thought processes coming to our mind. So just simple one sentence given by Albert Ellis, that you can't always change the world or what happens to you, but you can change the way in which you think about your experience. एक कहावत है हिंदी में, कुछ तो लोग का काम है कहना, yes or no? So whatever you do, if you will do right or wrong, people will say. So don't think that they will think like that, they will do like that. So don't think about that. So if something will happen due to psychological problem or due to vascular problem, mainly due to vascular problem, these 4 factors are coming. First is cognitive function, that is mental stamina, attention and concentration, sequencing, memory, internal certainty, automaticity is lost. Then some execution functions also, self-monitoring, problem solving and decision making. When it is coming physical, then they have fatigue, increased need of self-monitoring, internal states, increased sensitivity of physical stressor, that is some kind of disturbances of noise. There are some hallucinations coming. Visual stimulation, weather changes, diet, hormonal fluctuations, and dim environments. In emotional, they have anxiety, fear, panic disorders with or without agoraphobia, depression, interpersonal stress, changes in sense of self, self-efficacy, and identity. When you measure the social, in social, they are facing some problem like increased social isolation due to self-consciousness about symptoms, limited knowledge and or understanding vestibular disorders in general public. So first, people see the cognition and the processing, some negative perception of themselves and expectation about their performance. So when that negative impact is coming to, come to their mind, they are thinking that I'm physically not able to do that work due to maybe due to any postural vertigo, postural phobic vertigo or some kind of things. or in case of BPV also, selective attention of negative events and overlook and ignore the positive. Whatever they are inside positive attitudes, they are thinking, no, I don't have any positive attitude. If I'll do that like this, I'll face like that. So all kinds of emotional disturbances they are facing in their mind, and generalize failure in one area to others. Because due to that kind of social withdrawal tendency, or due to some kind of emotional problem, always they are thinking like that. So in one setting or in one session, you can't say that the patient has some psychosocial problem. It's very difficult to say. I have seen that some kind of patients where some doctors have recommended that this is a psychosocial problem. But ultimately, when I diagnose that patient, they are vestibular problems. So it is sometimes very confusing that you have to assess that which is psychosocial, which is vestibular. So why, if you'll see, I have gone through all the literatures. There are only 3 to 4 literatures available in different kinds of journals. In all 4 literatures are telling about cognitive behavioral therapy, but associated with your vestibular rehabilitation therapy or counseling. So 30 to 50% of complex dizziness individuals are organized related to psychiatric disorder or vice versa. Some people have past experience of vestibular disorder, then psychological problem develop, or either way. Like first they have some psychological problem, then they have some vestibular symptoms. So 30% of Meniere's disease, vestibular migraine, that is vertiginous migraine patients, subsequently develop psychiatric disorder. And why it is occurring? As you know, inner ear is very near to our limbic system, that is amygdala, your hippocampal area. So when we are going to do cognitive behavioral therapy, at the time of belief, that when a patient is thinking that not believing that his condition could be affected by psychological factors, one, when he is telling, no, I don't have any psychological problem. So that is one time. And at the time of willing to try anything, when he has gone he has taken a lot of medicines and everything he had done, then he is telling, give me something, I just want to do something, whatever he will tell. Okay, then now next is when nothing is working. Okay, these are the 3 conditions we'll do. So we'll do some functional analysis that I'll tell how we are analyzing those patients. That is functional analysis. We are analyzing the triggering factors and some high-risk situations. And what we are doing, the skill training we are doing to improve their cognition, emotion, social, and physical. So there are 5 approaches of cognitive behavioral therapy management. First is, are you ready? If you are going to do cognitive behavioral therapy, first ask yourself that, are you ready? Have you gone through all the articles? Have you read all the books? Have you tried somebody about cognitive behavioral therapy? If you are ready, then go with that. Because in front of patient, you can't counsel here and there. Then what to expect? You are expecting to handle the patients in a proper way. The very first day when the patient is coming to you, take some time, sit properly, and discuss with all the matters, all the prescriptions before take all the histories, and try to counsel the patient the very first time, and counsel in a relaxed manner. I'll tell how that is called desensitization. And the fourth is, what next? After one session, the patient will definitely expect, when I'll come. So take some time, give some time, and see what is the feedback from the patients. Then you can have the next sessions. And resources you can collect from the nets and books and other YouTube also available different kinds of therapy for anxiety, depression. You can take some ideas and utilize in dizziness patients. So there are 28 scales are available through nets. You can collect all the articles and you can collect all the information. But through that, I have collected all, these 3 are so useful for me, what I have seen. The Dizziness Handicap Inventory by Jakobson and Newman 1999. This is a scale which gives us idea about handicapness, that is physical, emotional, and social skill. Okay? And this is the very best handicap inventory, what we are using, and what are the other publications they are using. It has translated to 21 languages throughout the world, 21 languages. And personally, I have taken permission from Dr. Jakobson. I have translated into 3 languages, Marathi, Hindi, and Oriya. So if somebody is Marathi, they want to use it, so you can take from me also. So hospital anxiety and depression scale, that is Zygmunt and Smith in 1983. And this is Indian, third is the Indian, Dr. J. Bharatraj, Medico-Psychological Questionnaire. In that questionnaire, we are assessing obsession, hypochondriasis, anxiety, depression, then there are all the frustration and negativities. So after analyzing everything, from the first beginning scale, physical, emotional, and social factors, you can analyze how much the person is feeling about handicapness. It's mild, moderate, severe due to physical, or due to emotional, or due to social. If you will see the scale, there are 7 physical questions are there, 9 emotionals, and 9 functionals. So all the dizziness handicap scores are 96. It is 0, 1, 2, 4, 2, 3 criteria are there. So this is the mild handicap, moderate handicap, and severe handicap. If the patient is telling severe handicap, this is the best time to start with the therapy. So this is the best way how to handle the patients with vertigo and also related to psychological disorders. First is you have to motivate the patients. First is motivation. Second, identification. The patients should identify themselves, and you also identify what is the exact problem, why the patient is facing that kind of problem. Then give some self-monitoring technique to the patient, that they should write something in their clinical the diary, or they will self-monitor, okay, if I'll do this kind of physical activity, I'm facing problem, or in that particular situation, social gathering, I'm thinking that I will get some problem. So give some time, so they should monitor themselves. Then cognitive appraisal and restructuring. So according to that particular situation, you are just trying to modify, restructure that particular things. How? Now first you have to desensitize the patient. Give some relaxation or counseling first session. This is the very beginning first session. So desensitization. Then second is discussion and counseling. Without discussion, don't tell that you have some psychological problem. People will not accept that they have some psychological problem. When you will do some kind of therapy and you will show them, see, that's why you are facing this kind of problem. Then they will realize, okay, yeah, I am some kind of anxiety or depressions. Then modify their behavior. How you are going to modify their behavior? Some kinds of techniques are there, I'll tell. Then last, develop some alternating coping skills. How they will cope up to that particular situation. Some skills are, some trainings are there, some treatments are there that will do. And last technique is stabilization. Without stabilization, you don't have to leave the patients, because what it will create again relapse, and that relapse is so severe they will not come to again to you. Okay. So the coping strategies are first that self-monitoring, take breaks, give some input, give some counseling tools, and take breaks. Give time to yourself. Think that what I'll counsel the patient, then patient will cope up to me. Second, cognitive drill. If you'll still cognitive drill, suppose the patient is thinking, if I'll bend down, I'll face some kind of giddiness. If the patient is thinking like that, so tell the patient to write that and read aloud. Write and read it loud. When he will read it 100 times, it already confirmed that first when the patient will read, the anxiety level will high. After that, it will be saturated. Then again it will fall. So this is the one technique. And the memory activity, you will do some kind of memory activity. Lot of memory activities are in net, so you can collect the best memory activities. You can do at same time with the patients. The patient will feel good that the doctor is understanding me, or they are giving some time to me, so he is the best doctor. So daily diary, that's the best things. If they will write the daily diary, then they will say, no, yesterday also I did that. I didn't face any problem. So you can tell, okay, this is not due to physical. So why you are thinking like this is from physical only? Then listen before giving answer. Tell them, ki just listen. What I'm telling you, just listen. Or what others are telling, just listen, then give the answer. So they'll get some time to think actually. Otherwise they're thinking that my memory is not good, and my memory is not good, I'm not answering properly. and how you are handling the physical and social issues, that is identifying symptoms and triggering factors for stress, and learn some stress management skills. To reduce the stress management, only one tools is the counseling. That's the best things. And you can take help some kind of social stories. As I told, last thing, social stories. You just counsel about some stories like, I have seen that patient, they have done this kind of work. So they will motivate, okay, sir had already seen this kind of patients. So they will definitely take care of me. So tell some kind of stories. You can have some kinds of your chat books or some kinds of flashcards when you're handling those patients. Then it's okay to ask for help. Tell them if you have some if you have some problem. Tell others why you are hiding. If you are hiding, one cycle is there. If you are hiding that symptom, then you are facing some kind of negativity. If that negativity creates, then again it creates more problem to you. So don't hide. Take some help from others also, and learn the value of acceptance. They will not accept till the end of their any problems. They will not accept. No, I don't have any problem. And join a support group. If you are facing any problem, same way the stammering groups were telling that join a stammering group. Same way, if you will suggest to support a group, they will take care of a support group also. So what will do? What are the advantages for that? Suppose I am doing vestibular rehabilitation therapy. Only single vestibular rehabilitation therapy, the patient will not motivate. In one day he will come, 2 days he will come, and third day he will tell, no, I am very tired, I will not do. So, first of all, you have a chart session. So, always chart the patients. And what I've seen that people are giving some leaflet, brochures, patients are doing for 1 day, 2 days, 3 days, and after that they're thinking, I'll do for 1 month, or 2 months, or 3 months, I don't know. So, it's better to give some kind of cognitive behavioral therapy and also same time some vestibular rehabilitation therapy. Because if you give lot of work in 1 day, they will not do. And it's a non-invasive procedure, that's a very easy thing. An emphasis on getting better by learning how to recognize and correct problematic assumptions, the root cause of many problems. As you know, they have some kinds of, if you analyze properly, then you will get to know that, okay, this vestibular disorder occurs due to this psychological problem. Or due to this vestibular occurs first, then they have some psychological problems. So clearly defined goals and methods that can be evaluated using scientific methods. They will have a belief on you, then they will reduce their negative impact and they will improve their positive outcomes. These are all psychological problems where we are applying cognitive behavioral therapy, but nowadays postural phobic vertigo, Meniere's disease, vertiginous migraine, and some other psychological related aspects, vertiginous also, vertiginous attack also, we are counseling for the patient for cognitive behavioral therapy. What we are doing, what kind of factors affecting cognitive behavioral therapy? If they have faulty lifestyle. As I told yesterday, you have to change first lifestyle modification and diet. Same time, you have to, if the faulty lifestyle is going on, they will not accept the cognitive behavioral therapy. Second, if they have pain. If actually they have some kind of pain, during the physical activity or due to any kind of social emotional problem, it will not work. Third is the presence of other medical conditions. Fourth, if they are taking different kinds of medications. If they are taking psychiatric medications and same time other health related medications, it will not work. And emotional concern as they have depression and schizophrenia. If these two conditions are there, your cognitive behavioral therapy will be not working good. So I think this is the, I have to rush it because my train is there. So this is the last things I can tell you that these are new concept coming to our mind like diet, lifestyle changes and cognitive behavioral therapy. People are reading in books and literatures but not utilizing their daily clinical practice. I will suggest you, please go through this. Definitely your patient, you can handle the patient properly and the patient will have some best belief on you. Okay, thank you so much.